Thank you, everybody, for being here. It's time for us to start the 2025 winter meeting. It's an exciting time. The VES is one of everybody that's here. It's probably one of their favorite meetings. Rules of engagement for the meeting: there will be no coats, there will be no ties. I distinctly remember Jason Lee and Matt Courier giving me a really hard time when I was, if I wore something like that. So it's very casual. If you come in off the slopes because you barely made it back before your talk at 4:30, that's fine. Come in your gear, give your talk in your gear. It's perfectly acceptable at this meeting. I am Misty Humphreys. I'm the current president. Dr. Bjorn Suko, who is my co-moderator, a vascular surgeon at Dartmouth. Bjorn was my resident years ago, and now we're just reminiscing about how long ago it was that I was a fellow. He was a younger resident, much younger, and now here we all are, enjoying ourselves, having a great time, and really learning a lot of good science. So we're going to open up the first session of the meeting. And we're going to start with the use of wireless pressure sensors to prevent temporal loss in subbandage pressure during compression therapy. And we are going to have Molly Calkins come up and chat with us.
Good evening. My name is Molly. I'm a second-year medical student at Tufts University, and I'm here today with Dr. Robinson to discuss the use of wireless pressure sensors to prevent temporal loss in pressure during compression therapy. These are our disclosures. Venous leg ulcers are a common complication of venous insufficiency, with 11.5 million cases each year globally, and more than half of these cases experience delayed healing. This results in more than $14 billion annually in healthcare costs. For reference, VLUs are 500 times more common than TAAAs. The gold standard treatment for venous leg ulcers, as recommended by the AVF, is compression therapy, the goal of which is to restore venous valve competency. Therapeutic benefit requires that compression supplies an effective amount of pressure without being too loose or too tight, but studies show that 90% of the time, effective pressure is not achieved. Additionally, 80% of patients are not compliant, and this leads to a 20% projected reduction in healing rates. As a potential solution for these problems, my mentor, Dr. Robinson, helped design a wireless multi-point pressure sensor that continuously monitors subbandage pressure at 3 points. Shown here is an early iteration of the device. The sensing arm sits within a sleeve that can adhere to a layer of padding, such that the 3 sensors lie at positions B, B1, and C along the lateral calf, as shown. Compression bandage is applied on top of the sensor, and a detachable and rechargeable clip then wirelessly transmits pressure data for each sensor to a mobile device. The MPS provides the novel ability to continuously record subbandage pressure. Through this pilot study, we wanted to explore how this new information could be used to improve the consistency of bandage application, identify changes in pressure over wear time, and establish interventions to mitigate such changes. Our study consisted of 14 healthy volunteers. Each was given a Fitbit to wear for 3 days to track their activity, and each day a compression bandage was applied over the MPS according to one of 3 interventions. Volunteers were then instructed to perform a standard set of activities consisting of lying, sitting, standing, and walking around 0, 6, and 12 hours after application. Using the data collected, we plan to look at the mean subbandage pressure for each activity, as well as the percent of applications within the target pressure range. Here is an example of what the pressure readings captured by the MPS look like. From these readings, we were able to calculate a mean subbandage pressure at each sensor position for each activity. to account for any variability in time spent performing activities, and when changing between activities, the middle 2 minutes of each 3-minute activity was used for analysis. Our first 2 interventions involved applying the bandage with either visual indicator guidance per the manufacturer's instructions or with lateral digital guidance from the MPS with target pressures of 40, 40, and 30 millimeters of mercury at the ankle, mid, and upper calf, respectively. With only visual indicator guidance, the majority of bandages were applied below the target range at the B and B1 positions. But live MPS guidance significantly increased the percentage of applications that fell within 5 millimeters of mercury of the target pressure at these positions. Even with guided application, there was a significant loss in pressure throughout the day at all 3 sensor positions. This graph shows the average pressures during standing periods, but significant decreases were seen for other activities as well. In an effort to prevent this temporal loss in pressure, we introduced the top-up intervention. Following application to the same target pressures of 40, 40, and 30 with live digital guidance, participants were instructed to check the pressure at each sensor position at 6-hour intervals using the mobile app. If the pressure had fallen more than 5 millimeters of mercury from the target, they were to apply an additional circumferential wrap in that region until the pressure was once again in range. Out of the 14 participants, over half required this top-up at some point throughout the day. 43% utilized it at the 6-hour mark, 7% at the 12-hour mark, and 7% at both 6 and 12 hours. We then compared the average pressures at each sensor for each activity at each time point with and without the top-up intervention. If you remember earlier, I showed that without readjustment, the mean subbandage pressure decreased throughout the day. But if we compare the pressures after 12 hours, introducing the top-up intervention led to a significant increase in pressure at the C position while supine, as well as when standing and when walking. There are some limitations to this study. The data comes from healthy volunteers, limiting generalizability to VLU patients, and with only 14 volunteers, the sample size is relatively small. Additionally, we discovered some technical issues with the early iteration of the device that impacted our ability to collect continuous data. However, our data suggests that live guidance with MPS does allow for more accurate application of compression bandages and that the device can detect temporal losses in pressure. Additionally, utilizing the top-up technique can mitigate these losses in pressure while encouraging patient empowerment and self-management. We are looking forward to continuing our analysis and incorporating the Fitbit data we gathered. Our goal is to use this study as a model for future studies involving VLU patients. Thank you so much for your time, and I'd be happy to answer any questions.
Hi, Molly. Very nice presentation. I'm Jeannie Ruddy from the Medical University of South Carolina. I think it's great that you were able to demonstrate this was effective on healthy patients, and I understand your movements forward with your ulcer patients. I was just curious, when it came to coaching the patients at home for the initial application as well as the top-up intervention, did it require additional nursing staff to be reaching out to the patients, or how was the physician team able to confirm the patient compliance?
So the initial application in the morning was done in office, and so that was applied by nurses, by staff that knew how to properly apply it, and then they taught the patients how to add the additional wrap if they needed to at home. But when patients were at home, that was on their own, so there is definitely some questions around compliance, but I think that actually is helpful in this case because it's more accurate of real life. What are patients doing at home if we're asking them to check their bandage?
Well done, excuse me. Well done, Molly. Chris Audu from University of Utah. Question for you: how many weeks did these patients wear this wrap? And then, secondly, did you have any controls of patients without the wrap or without any sensors? What were your controls?
Yeah, so they wore the wrap for, it was around 4 days sometimes. A day had to be repeated if there were issues with collecting data or something went wrong. Dr. Robinson,
yeah, I can jump in
because
Molly did most of the data processing and analysis, but the clinical stuff was sort of done before she got involved with the project. And I will say that we started, this was a learning process. It was sort of a new device, never used before. We didn't know what the data would consist of or how we would even use it. So there was a lot of troubleshooting. And healthy volunteers who aren't used to wearing compression stockings, we wanted them to wear it for a 24-hour period. But the first group of patients that we put through it after they wore it, they came back like the next day with the compression bandages on, and they were like, none of them slept because it was so painful and uncomfortable. So at that point, we cut it back to just like a single day time point for each. So like we didn't want to have any sort of negative, critical events here, safety events with the device. So it was just a 12-hour period.
Thank you for the presentation. This is obviously a really interesting device. I just wanted you to clarify, when you were first measuring or comparing the visual guided application of the compression wraps versus your live information based application of the compression wraps, how are you measuring the pressure? It sounded like as you were going through this, that the pressure sensor that was it was also the experimental condition, that was what you were comparing the visual guided application to, was also the way that you were measuring pressures. Was that?
Yes, so in this case, with the visual guidance, there was still the sensor underneath, and so when they were applying the bandage, they weren't looking at the numbers. We looked at the numbers after. Yeah. But previously, not included in this study, there was some data looking at how accurate are these pressure readings using comparison to other devices that have been used to detect pressure, but those devices don't do a continuous reading. It's like a 1 point during application, if that makes sense.
No, it does. It's just sort of a nitpicky point. I think if the instrument to measure the pressure is both the instrument that you're comparing the standard of care to, you might have a slightly prejudiced outcome where clearly the one is going to be more accurate, the instrument that's measuring the pressure, as opposed to the visual application. But I think overall, it's a really awesome device, and thanks for the presentation.
Good. Thank you very much.